I'm truly honored and humbled to be here. Thank you, Rob, for the kind words, and thank you, Sudhir, for inviting. And most importantly, I thank my mentors, some of them, my teachers, some of them who are here, Adnan, Jose, among others, so thank you. So before I start, a quick question to the learned audience. How many of you would support no trial in majority of your patients? Come on, don't be shy. If you no trial group, so we'll have a randomized study here. Okay. So those are my disclosures. So I have educational and financial disclosures, so don't believe in what I say completely. Why this talk? We are all required. So the current rule is we have to do trial for spinal cord stimulation as dictated by our national bodies. We have NICE in the UK. You got National Institute of Health and the FDA. So we need to do a trial. Now the evidence suggests over the last 20 years, the success of the trial has gone up gradually from about 67% to 86% over the last 20 years. So when a trial success rate goes up, it is seen that it decreases its value and it increases the cost of care if fewer number of patients are failing the trial. So the opinion is divided regarding a trial as a predictor for successful long-term outcome from a spinal cord stimulation. It is argued that there are a lot of false positives and false negatives from spinal cord stimulation, and should we be really doing a trial? So before we actually address that question, it's good to look at the papers that the insurers or the funders are looking at this point. And this was JAMA, which Rob and others alluded to. It's created a little bit of news in the media, and the insurers are gunning for taking the reimbursement away from spinal cord stimulation. So essentially, JAMA, negative study, and the conclusion is patients with chronic radicular pain after lumbar spine surgery, what we used to call a failback surgery or persistent post-surgical pain syndrome, compared to placebo, have the same outcome. So as implanters, are we living in la-la land saying, let's do implant for all these patients? And doing a implant without a trial, does it have a longer or does it have other implications, such as the same argument can be applied to pain management programs? Can the insurers then say you don't need psychology because it's end of the day, it's all about cost, right? And on the background of medical legal work that I do with the incontinence mesh, we just concluded a case where it was nothing out of ordinary. The payout was $1 million for a patient who had an incontinence mesh put in. So implanting device is a dangerous business, especially if you don't do it properly. Good news. What's new? Again, machine learning and AI-based algorithms have been hugely successful in medicine, but the scope has been limited, and this publication that came out last year says that AI prediction is better than lead trial. On closer look, of course, this was done with 103 patients. With AI and machine learning, you get out what you feed in. So if you feed good stuff, you get gold. If you feed shit, that comes out. Sorry for the. So this is based on 103 patients. It does not represent real-world problem. The models use the logistical regression, the randomized logistical regression. They're all good, but the randomized forest plot and some other models used may be not applicable to spinal cord stimulation. So as with most studies, further studies are required. So the elephant in room, the question, the case for no trial. And this is where experts argue that if you have the right patient, you can go straight to implant, you save time. The patient inconvenience of having loose wires sticking out of your back, and then using your resources. The waiting list in UK can be as long as 2 years from the time they refer to us. So should we trial, or should we just go ahead and do it? So the first thing I did when Sudhir asked me to do this talk is I wrote a nice email to Sam. Dear Sam, you're a good friend. Can I have your presentation that you so elegantly did over the last few meetings? Because he had already published on this 6 months data. So I got a reply. It was not very positive. He said no. And he said, however, there's a publication that's coming out, 36-month outcome, trial versus no trial, and you can have the preprint version for your talk. And since then, it's been now published. So this group has been looking into this, and Sam Eldabe, Simon Thompson, and others, who are good friends, have published the outcome of the 36 months randomized controlled trial. So this was a pragmatic randomized controlled trial where the primary outcome was pain intensity, so numerical rating scale. They looked at 50% and 30% reduction in pain scores from 6 to 36 months, and they have published this data. Okay, so I know it's been a data-intensive day, so I'll try to keep it simple because I don't understand data too much myself. So 137 patients were screened. They randomized 105 patients. One group, that is the trial group, had 54 patients in the trial, and 51 patients they implanted straight away, so they didn't do the trial. At 36 months, they followed up 30 patients in the trial group and 36 patients in the non-trial group. Okay, so that is the simplified version. Okay, results. So the primary outcome was NRS. Oh, sorry. It wants to go to Sudhir. So the primary outcome was NRS, and they met their primary objective as stated. There was no difference in the primary objective of the pain intensity and secondary objectives such as the quality of life, adverse events, as reported by the authors. There was no difference. So the conclusion, so we're all happy, right? The people who raise their hands. The long-term results show no patient outcome benefit in undertaking a trial. So now, how many of you want to do a trial? How many of you are in the no trial group? Have I converted you? It's a no trial group? Okay, I can see there is a 400% improvement in the outcomes. So, right, so I was excited too. So I went to our board, I went to our trials unit, and I said, can we change our practice? We got an RCT, and we had a meeting. So it was not a pleasant one. So, so the study design is pragmatic, which implies there's a flexibility in how pain is measured, and the outcome is measured in terms of pain intensity, NRS score, with 30 to 50% reduction. And the funders say that this is low bar. So this study can be seen as a clinical superiority trial or equivalence. It requires data in real life. And NRS-based studies are subjective. Okay, so I said, that's all right. So what about cost? You're always harping about saving money. So this is going to save us money. And we looked at the paper, and the cost effectiveness at 36 months was not done in this study. And in the UK, the Department of Health, apart from this, they need a full-scale evaluation to change practice. So, right, okay, what about the complication rate? So we looked at the complication rates from device studies, and they said the sample size was too small to comment on complication rates to change a practice. Okay, we went back to the paper. So the paper says clinical utility and cost effectiveness, whereas the conclusion says long-term results show no patient outcome benefit in undertaking SCS screening trial. So the board felt there is a disjoint between saying it's cost effective versus the pain scores are similar. Further, the dropout rate in this study is it's 38%, so 66 of the 105 patients actually completed the trial at 36 months. And this is conservative, it's higher than that. In the trial group, the dropout rate is 26%, and non-trial group 36%. So there's a 10% difference within the group. And if we are doing a study and if there's more than 10% dropout rate, we need to look at it and maybe have better follow-up procedures in place. Quality of life, again, the objectives, that has to have clear cutoffs if you are looking at quality of life. One of the biggest points that was made was when you have a rigid cohort selection, and that is what was when the first few people raised hand, like Jose, Robert, they are experts, they are key opinion leaders, they know what they're doing versus an implanter like you or me with less experience. Our patient selection might not be as good as people doing the RCTs or the key opinion leaders. So if it goes out in the open and every implanter is not doing the trial, the outcomes might be different to what Jose and Rob are doing compared to what you're doing. And of course, there was a high risk of bias, and these were the disclosures from the speakers. And our board at UCL especially, it's frowned upon, and even me going in there with my disclosures was not very pleasant. So essentially what we were looking for is performance evaluation, not procedural success, because this is a study of trial versus non-trial, not if SCS works or not. And for performance evaluation, it's essential, and that's an essential criteria for pre-qualification assessment or abridged pre-qualification assessment for any device. And an independent verification is essential if you want to change your practice when it comes to implanted devices. So while the study was a procedural success, it cannot be seen as an indicator of diagnostic performance. Okay, so even the authors in their verdict said, we do not suggest that screening trials should be eradicated, but they should not be made mandatory. Now, before we hang our coat on the previous study, I came across this study, again published earlier this year. This is the Israeli study. I'm not sure how many of you have seen this. Has anyone seen this one? This is probably slightly worse than the publication in JAMA. And I was not aware of it until I appeared in a court recently when I recommended spinal cord stimulation for a neuropathic pain, when the defendant lawyer waved this publication in front of me. And what it says is, it's comparing the group that had a failed trial was compared to the group that had an implant. And essentially at 7 months, so this is the line with the pain intensity, and these patients have failed the trial and they didn't have an implant. And this group had the implant, reduction in the pain intensity, and at 7 months, they meet each other. They said, Dr. Shetty, SCS in the long term. And the conclusion here is, it appears SCS may not be effective for majority of chronic pain patients. Despite significant short-term improvements by the end of 7 months, the outcome in the treatment group were similar to those of the control group. And it's quite bizarre that these two studies have come out at the same time. So the conclusion is Sam should have given me his presentation. So for now, based on the evidence, I don't think we can challenge NICE or the NIH for us not to do trial, especially for routine use. The solution is possibly making trials more cost-effective, using advancements in technology such as wireless technology, which are less invasive, AI-assisted trial. And for those of us who are experts, you can continue following your execution without the trial. So I'm ahead of my time. So the reason is, if you had questions, and I was expecting either Sam or Simon Thompson to be in the crowd, but they're not here, so I'm lucky. So if you have any questions, I'm happy to take questions in my allocated time. Thank you.